Welcome to Moving Medicine, a podcast by the American Medical Association. By 2036, there will be an estimated shortage of 86,000 physicians in the U.S., according to the Association of American Medical Colleges. In today's episode, AMA immediate past president Dr. Jesse Ehrenfeld is joined by AMA experts to discuss the impending physician shortage and how to fix it. Experts from the AMA include Dr. John Andrews, Vice President of Graduate Medical Education Innovations, Senior Attorney Alexis Pierce, and Christopher Sherin, Assistant Director in the Division of Congressional Affairs. Here's Dr. Ehrenfeld.
Thank you, everyone, for joining us in our latest series focused on our nation's worsening physician shortage crisis, the implication for patients and our health systems, and what are some of the solutions to fix it? It's now estimated that more than 83 million people in the US currently live in areas without sufficient access to a primary care physician. There are large parts of Idaho, large parts of Mississippi, where pregnant women can't find OBGYNs to care for them. 90% of US counties in the US are without a pediatric ophthalmologist, 80% without an infectious disease specialist. More than a third of Black Americans live in a cardiology desert. And in Florida, my own parents lost their primary care physician because the Medicare payment rate for doctors has plummeted over the last 2 decades and pushed many independent physician practices towards financial ruin. So the physician shortage that we have long feared and warned was on the horizon, it's already here. And it's hitting every corner of this country, urban and rural, with the most direct impact hitting families with the highest needs and the most limited means. While the physician shortage is a crisis today, there is reason to believe it's going to get a lot worse unless we take immediate actions to address it. Think about the fact that roughly 2 in 3 doctors experienced burnout during the pandemic, according to our own AMA survey. This is the highest level of burnout we have ever recorded. Consider that nearly half of all practicing physicians in the US today are over age 55, getting close to retirement. And while medical school applications are up and some new schools are coming online, it can take a decade or more to educate and train a physician. And when you think about physicians in large number who are already reducing their hours, contemplating leaving the profession altogether, there's trouble ahead. The latest projections from the Association of American Medical Colleges anticipates a physician shortage that could reach as high as 86,000 physicians that we won't have when we need them in the US over the next decade. And even if the actual shortfall is much less, it will still have an enormous implication for our healthcare system and for the ability of Americans to access the care when they need it, where they need it. Imagine walking into an emergency room in your moment of crisis, in desperate need of a physician's care and expertise, and finding no one there to take care of you. That's what our patients may soon be facing. And it's the reason why we're here today, because there are real-world solutions to this complex puzzle if we can apply enough pressure to policymakers to make the necessary changes. So with us today are 3 of the AMA's in-house experts who are going to help us understand what's going on and what's needed to fix it. We've got Dr. John Andrews, the AMA's Vice President of Graduate Medical Education Innovations. We've got Alexis Pierce. She's a Senior Attorney in the AMA's Division of Legal Counsel. We've got Christopher Sherin, an Assistant Director in the AMA's Congressional Affairs Office in Washington, D.C. I want to thank you to our 3 panelists for making time for this really important conversation. Let me jump right in. John, I talked about this in the introduction, but can you please tell us in a little bit more detail about the physician workforce crisis? How has it evolved in recent years, and how did we get to this crisis point?
Thanks, Jesse. It's nice to be with you today and with Chris and Alexis to talk about this important issue. You know, the debate about the number of physicians in the United States has been going on for a long time. 30 years ago, the conversation was very different. In the mid-90s, there was great concern that we were training too many physicians. And that probably related to concerns about expanding healthcare costs. It was a time when graduate medical education programs were capped and there was reluctance to expand medical school admissions. Now, 30 years later, the conversation is very different. The pressures that we're seeing now, as you noted, are an aging physician workforce, frankly, an aging population. And as our population ages, the healthcare needs of the population increase, and concern about whether the physician supply will meet the healthcare needs of those populations. But I want to be cautious about oversimplifying what is a complicated issue. And we need to go beyond just talking about the numbers of physicians that we're training. You yourself cited anecdotes, for example, about access to obstetric care in Idaho and Mississippi. And by simply training more obstetricians, I wouldn't be confident that those obstetricians would go to work in Idaho and Mississippi. So there really is a need to match our physician workforce to the needs of the population. And one of the real critical issues that we need is some sort of central workforce strategy that acknowledges what those needs are and helps us to understand how to train physicians to meet those needs, both in terms of capacity, but in terms of distribution on the specialty and geographic basis as well.
So you work in the medical education department here at the AMA. How are you seeing this crisis play out in our medical schools and our residency programs as you look across the country?
Well, there, I think it's a good news and bad news situation. On the good news side, the physician supply is increasing. Over the decade of the 2010s, medical school classes increased by 20%. And over the last decade, medical school classes have increased at roughly about 2.5% per year. And GME positions are increasing at a rate faster than that, 2.8% per year. There were over 1,100 new positions offered in the main residency match last year. So the physician supply is growing, but those concerns about whom we're training and what they'll go on to do persist. At the medical school and the residency level, one of the challenges is because of structural barriers, the way GME is financed, for example, the way clinical experience in medical school is obtained, it becomes difficult to find sites to train people in the areas that are most needed. You mentioned primary care, you mentioned rural areas, and our current structure that supports training in large urban academic medical centers limits access to opportunities for us to create training in those areas and also to create excitement about the possibility that someone might go to work there.
Medicine doesn't stand still, and neither do we. AMA members don't just keep up with medicine, they shape its future. Help move medicine, join the movement. Visit ama-assn.org/movingmedicine.
So let me bring Chris into the conversation. It's clear that this is a multifaceted issue and one solution isn't going to be enough. What are the prongs that you see of solutions to this sort of larger workforce issue?
Yeah, thanks, Dr. Ehrenfeld. And it's great to be here as well. This is a multi-pronged solution that we need to have here as it relates to this particular problem. The first part is really focused on payment reform. We want to keep as many of the physicians that are currently in practice staying in practice. And that's where payment reform really comes into play. The second part, though, is we obviously have to train more physicians. And we'll be able to do that by addressing the Medicare supported residency cap. And I know Alexis is going to talk about that a little more in depth, so I won't steal her thunder right away. But that's another main part of our solution. Then the third one is, because as we all know, it takes approximately 10 years to train a physician. Even if we passed some of those GME support legislations or bills right now, we still need to do something to fill the gap. And that's where targeted immigration reform can come in and trying to increase the number of international medical graduates. So those are our three prongs.
Makes a lot of sense. All right, so Alexis, can you talk a little bit more about these residency cap issues that we're experiencing right now and trying to kind of work through at a congressional level?
Yeah, sure. Thanks. I think that John did a good job of laying out some of the big, themes that we're seeing in terms of the issues that we experience with the residency and the residency cap. So I'm just going to give a little overview about what some of those things are and kind of expand on what he's already stated. So even though the federal government isn't the sole contributor to GME, it is by far the single largest payer, primarily through Medicare funding. And as John had mentioned, Congress used to fund GME positions, like without the cap that we currently experience. But in 1996, this changed because Congress decided to restrict the amount that it would contribute to physician residencies through limits on the number of resident full-time equivalents and per resident amounts that it would support in the Balanced Budget Act of 1997. So in other words, the number of positions that Medicare supported in each hospital in 1996 was established as the upper limit in terms of the number of positions or slots that Medicare would fund in those institutions thereafter. So they put it on the cap. The cap is not absolute, as John had kind of mentioned. There are various ways that you can increase that, including through constructing a new hospital, having rural programs start new GME programs, have urban hospitals start programs that have significant training time in rural areas, and there are a few other ways. But really, these increases aren't meeting the demand that we have. As such, the cap has significantly impacted our physician and patient population in many ways, including not allowing for care to shift and align with the population and geographic changes that have occurred in the past 30 years since the cap was instituted. Moreover, due to the cap, the residency positions have not been able to adapt and change as needed with our population. As U.S. Medical School has increased enrollment, residency training positions at teaching hospitals haven't kept up with the larger pool of applicants because they're limited by this cap. As a result, there's been a 52% increase in medical school enrollment since 2002. However, available residency positions haven't risen at the same rate. This lack of appropriate expansion has led to a bottleneck of medical school graduates who now need to complete their residency but don't have a slot that they can go into. This has caused the competition for residency slots to increase dramatically over the years, with the average medical school graduate in 2021 submitting 73 applications. This is a 24% increase in the average number of applications submitted per applicant compared to 2017. This means that the average number of applications being received for each slot is more than 60. That's like a huge amount. But thankfully, some progress has been made in this space. For the first time in nearly 30 years, 1,200 new Medicare-supported GME positions have been added thanks to the 2021 and the 2023 Consolidated Appropriations Act. So we're making some progress. However, it is vital that more Medicare residency positions are added so that every physician can obtain a residency slot and so that patients can have access to the healthcare that they really need.
Makes a lot of sense. Our good friend Tom Naska over at ACGME said recently that every physician who graduates from medical school who's capable of doing a residency ought to have a residency. And unfortunately, we know that that's just not the case because of the cap on those numbers. So, Chris, there are a lot of bills out there in this space that get batted around that might be able to help address the issue. Can you walk us through what might be on the table?
There's a multitude of bills, which is a good thing. The biggest bill that's out there is the Resident Physician Shortage Reduction Act. This is HR 2389 and S 1302. This is a bill that would allow for the cap to be removed, and then it provides 14,000 Medicare-supported GME slots over 7 years, so about 2,000 slots per year. And it really does build off of the progress that Alexis mentioned with the CAA in 2021 and then 2023. It's important to note too that this bill, it tries to make sure that the slots are going to the places of most need. 10% of those slots need to go to hospitals with diverse needs, like hospitals in rural areas, hospitals serving patients in health professional shortage areas, hospitals in states with new medical schools or branch campuses, and then also hospitals already training over their cap. And it's important to note too that a portion of these slots are supposed to be reserved for hospitals that serve health professional shortage areas and are also affiliated with historically Black medical schools as well. So it's another way to try and help with the diversity of the situation. But no single hospital can get more than 75 slots. The other thing we're trying to push for as well is for Congress to pass something similar to the Physician Shortage GME Cap Flex Act. We don't have a bill in the 118th Congress, but we've had it in the 116th Congress. And this would really allow for GME teaching institutions to extend their cap building window for a total of 10 years. So you get 5 years beyond the initial 5 years that you get as well. The other bill that we also are pushing is the Substance Use Disorder Workforce Act, the SUD Workforce Act, as we typically refer to it. This bill provides 1,000 GME, Medicare supported GME slots, specifically over 5 years in hospitals that are in the process of establishing or will establish these residency programs in 3 specific areas: addiction medicine, addiction psychiatry, or pain management. In 2024, if the bill passes, it gives us 500 new slots, or 500 slots for existing hospitals in those 3 areas. But between 2025 and 2028, we get 500 slots for those new hospitals setting those residency programs up in those 3 specific areas. And again, no specific hospital can get more than 25 slots. And then the final thing that we really need to talk about is some student loan relief. And that's where the READY Act comes in. The acronym stands for the Resident Education Deferred Interest Act. And this would really allow for borrowers to qualify for interest-free deferment on their federal student loans while serving in either a medical or a dental internship. So hopefully the combination of the relief for dentists and physicians helps with the political support for it. There's often programs out there that will allow you to defer your loans, but to get it interest-free, that's the key part of this particular piece of legislation. And that's why we're so confident that it's a good bill. So I could go on for the rest of the hour here, but those are 4 that are really good.
Well, that's great. It's really nice to hear that Congress is thinking about these issues. Let me transition back to Alexis and the need for immigration reform. Alexis, can you kind of walk us through how immigration reform itself can positively impact the physician workforce and patient access?
Yeah, and John kind of laid out some of the themes for this as well. When he noted that, we have an aging population. It's projected that by 2032, there'll be a 50% growth in the population, those 65 and older, and only a 3.5% growth in those 18 or younger. And partly due to this phenomenon, we're going to have the shortage that you mentioned at the top of the program of 86,000 physicians potentially. As such, there's a growing need for a larger physician workforce, and the U.S. can't fill it on its own, in part because the U.S. physically does not have enough people in the younger generation to care for our aging country. In 2019, the State Physician Workforce Data Report found that nationally, almost 25% of active physicians providing care in the U.S. were international medical graduates, or IMGs. And building upon this, there are more than 12,000 physicians from 130 countries engaged currently in residency and fellowship training all across the United States. In 2017, nearly 30% of medical residents in the U.S. were IMGs, with about half working as physicians in the U.S. on non-immigrant visas, such as J-1s. These IMG physicians not only serve as vital members of the care team, but they lend to diversity of thought and experience that's invaluable to our U.S. healthcare system overall. These IMG physicians play an irreplaceable role in serving patients throughout the U.S. that are most in need, with more than 20 million people living in areas of the U.S. where foreign-trained physicians account for at least half of all physicians. Furthermore, foreign-trained physicians are more likely than U.S.-trained physicians to practice in lower-income and disadvantaged areas, as demonstrated by the fact that over the past 10 years, more than 10,000 J1 IMGs have worked in underserved communities. However, the physicians experience numerous immigration hurdles that they have to overcome throughout their career. When J1 physicians were surveyed by ECFMG in late 2019 and asked to describe the challenges to their well-being, almost 8,000 physicians noted that fluctuating immigration laws contribute to a unique set of stressors for them. Further, 63% of male respondents reported that visa and immigration concerns were among the top issues impacting their overall wellness. This isn't surprising, since each administration can enforce immigration laws very differently. However, if smoother pathways are created for IMGs, there will be significant positive impacts for the U.S. healthcare system, since immigration reform could help to ensure that our physician workforce is able to adequately meet the needs of our population. If key immigration reform efforts were enacted, we could ensure that our U.S.-trained IMG physicians are able to remain in the United States and continue to care for their patients, build up practices, and have personal stability. Finally, physician immigration reform could help our country ensure that our underserved populations have access to physicians.
Well, clearly, our international medical graduates are such an important aspect of the physician workforce. And I also just have to comment that my own pediatrician growing up was an international graduate from Venezuela. And my internist, when I got a little bit older, was an international graduate from Ireland. And they were two of the most incredible doctors I have ever met who inspired me in many ways to go into medicine. All right, let me come back to Chris. Are there any bills in the space that might help out our international graduate colleagues?
So Dr. Ehrenfeld, I'm sure you'll be surprised to hear that there are a multitude of bills related to this particular area. And I think it's important to note, too, that this is just one prong of the approach. There's been some comments about replacing USMGs. This is just a complementary piece of it. So I wanted to be clear on that part. But one of the biggest bills that we support as it relates to the IMG prong of our solution is the Conrad State 30 and Physician Access Reauthorization Act. So physicians come to the United States on a variety of different visas, but the most commonly used visa is the J1 visa. And this is a very versatile visa. And what I mean by that is it's applicable for all different types of individuals. So you'll have government visitors, you'll have professors, you'll have au pairs, but there's also this category of alien physicians as well. And the way the J1 works is you come to the United States, you're supposed to complete your unit of study or work, you sharpen your English skills, and then you're supposed to go back to your country of origin for 2 years before you're allowed to apply for a new visa or green card. So when this was set up, it's designed for individuals to essentially go back and spread the good news of the United States, which makes a lot of sense for professors and au pairs and other individuals. But for the specific category of alien physicians, it's a huge missed opportunity. So what Senator Ken Conrad did back in 1994 was he created this program that allows for each state in the country to get 30 waivers to issue to those J1 physicians. So you do not have to go back to your country of origin for 2 years in exchange for working in an underserved community, a health professional shortage area or a medically underserved area for 3 years. And every state in the country has utilized this program since its inception in 1994. The program just basically had its 30th birthday. What we're trying to do, though, is because it's been 30 years, we need to make some targeted improvements. So our bill would reauthorize the program for 3 years from the start, from the date of enactment, and get off of the appropriation cycle. It also creates a process to increase the total number of slots from 30 to 45. We'd never go below 30, but it would incrementally increase it up by units of 5 as long as the states continue to fill their slots. And then it also includes some really important transparency provisions as it relates to the contracts that the physicians have to sign. To me, though, the most important part and the most interesting provision in the bill is if you're willing to serve in an underserved community or a VA facility for 5 years, you get the opportunity to get expedited consideration for a green card. Our bill intentionally does not touch the total number of green cards that are issued, nor does it touch the per country green card cap, but it does for especially Indian and Chinese physicians who have to wait quite a long time to get one of these green cards. It allows you to get to the head of the line. And if you're willing to serve in those underserved communities or VA facilities, it's a real nice trade-off. This is a benefit for all physicians. I think the most important thing, though, is the 3 years that you would serve as a Conrad physician, that would count towards your 5 years overall. So that's one of the big bills that we have out there. It's doing very well in the House. It has close to 100 co-sponsors and 23 in the Senate. We also have a couple of bills that would make some changes around the edges to Conrad 30, which we think, while we do support as standalone bills, are best served to be added as an amendment to the Conrad 30 legislation I just described. One of them is the Doctors Act, which starting in 2025 would consolidate the unused Conrad waivers and allow them to be redistributed for an additional fiscal year to those states that are already using all of their waivers. So it really allows for those precious waivers to not go unutilized. And then we also have another bill called the Doctors in Our Borders Act, which is just in the House. It's Representative Mike Lawler and Shri Thanadar. And that bill would allow for J1 visas, the waivers to increase from 30 to 100. That would be the number that's given to each state. So we'd start referring to it as the Conrad 100 program, which would be a nice thing to say. Outside of the Conrad 30 program, we also have the Healthcare Workforce Resilience Act. Now, this bill would recapture 15,000 unused employment-based visas for physicians. It also would recapture 25,000 of those for nurses. It's another great bill. These unused visas would be from 1992 to 2021. And if the bill passes, we get a 3-year period to recuperate those. So I think you take the combination of those 3 bills and you can see that there's a wealth of solutions out there that Congress should pay attention to. And we're pushing them very hard to make those changes and enact those bills as quickly as possible.
Well, thanks, Chris. I hope that we can get some of those really important pieces of legislation passed. It never has made any sense to me that an international graduate can come, practice under a J1 visa, learn our systems, learn all of the workarounds, the frustrations of dealing with prior authorization, figure out how to navigate getting people the care that they need. And then we require them to leave for 2 years before they can come back. It's just irrational. So even if those pieces of legislation that you talked about are passed, it's not going to matter if we can't keep physicians in practice for the long term. So Chris, talk us through how payment reform is also such an important long-term piece to make sure that we maintain and build a strong physician workforce.
Certainly. And it's really quite simple, Dr. Ehrenfeld. We need Congress to pass legislation that's going to enact comprehensive payment reform, because as I mentioned before, we need to keep as many of those physicians that are currently practicing to stay in practice. And how do we do that? We need to make some real targeted improvements to the physician payment system. Now, most of you will recall that we were successful in getting some of the most recent cut mitigated, not all of it. There's a 3.37% cut that actually did go into effect in full for a few months on January 1st of 2024. What Congress was anticipating that cut coming down the line again, and they did pass in the Consolidated Appropriations Act a 1.25% increase to the conversion factor. But that was gobbled up, and we were really stuck with that 3.37%. So AMA, as well as the other members of the House of Medicine and all of you that sent those emails, made the phone calls, did the shoe leather lobbying, came together, and we were able to get an additional 1.68% increase to the conversion factor in the Consolidated Appropriations Act of 2024, which was passed in March of this year. But I want to emphasize that that is not a solution, and this was just a piecemeal approach, and it didn't even solve the entirety of the cut. So what are we doing at the AMA to try and provide that long-term solution? We have a bill, HR 2474. It's the Strengthening Medicare for Patients and Providers Act. This is our legislation that would provide physicians with a permanent annual inflationary update in Medicare, and it's tied to the Medicare Economic Index. So that gap chart that all of you have seen and likely used on Capitol Hill would close in terms of what we are being paid over the last 20 years as physicians, and what physicians are being, what the cost of running a practice as measured by the MEI really is. It closes that gap. So that's a huge part of this, another three-pronged solution. The other part that I want to emphasize is budget neutrality reform. And this is HR 6371. This is the Provider Reimbursement Stability Act. And as you know, many of these particular cuts that we're faced with are stemming from budget neutrality and the Medicare physician fee schedule. The threshold has not been increased from $20 million since it was enacted in legislation from 1988 and really 1992. So the first part of our bill would increase that threshold from 20 million to 53 million. We also would allow us to get away from being stuck with that specific figure, because we would index that figure for inflation. It would be the cumulative MEI over 5 years that would increase that $53 million. The other part of the bill, though, that's really important is the look back. It requires, whenever there's a code that receives a utilization estimate from CMS, that particular code would then have to be reconciled against actual claims data over a 2-year process. So whenever the conversion factor is altered as a result of those particular changes that stem from utilization assessments that, quite frankly, are usually incorrect, we're going to now do something prospectively about that. We're going to say the utilization assessment is not accurate. You can compare it to the claims, and therefore the conversion factor needs to be updated prospectively. So it's a great way to try and make sure that the fee schedule stays accurate. The best examples are things like the chronic care management codes, the transitional care management code, even the G2211 that just went into effect for inherently complex patients for evaluation management services. These are the things that we're going to double check CMS on. The other part of the bill too is it would provide a standardized calendar in terms of practice expense RVUs and the direct inputs and how they're reviewed by CMS. Things like clinical wages, prices of medical supplies, and prices of equipment, they're going to be reviewed no later than every 5 years. So we're not going to have the clinical labor situation after 20 years that created a lot of unrest in the physician fee schedule, or the changes to equipment that also happened for the first time in 20 years most recently. So that's a very important standardized calendar that we need. And then you'll see a provision in the legislation that would stop any sort of swing in the fee schedule by more or less than 2.5%. In other words, the conversion factor can't go up and down by more than 2.5% in a given year, really helping us get away from those wild swings. That's our budget neutrality legislation. That's the second part of our payment reform strategy. The final thing, too, I'd be remiss if I didn't mention MIPS. We have very close to unveiling legislation that would provide real reform to the MIPS program. It would get rid of the tournament style. So high-performing physicians are not being supplemented by poorly performing physicians in the MIPS program. We would improve the measures assessment process, and we would also ensure that physicians have access to real-time data. And if CMS fails to provide that data to physicians, they would not be subjected to those annual cuts as well. So it's another way to really force CMS's feet to the fire on this. So when you think of it, it's another three-pronged approach to this particular problem: MEI, budget neutrality, and MIPS reform. If we can enact all of those particular pieces of legislation, undoubtedly we'll be able to keep the current population of practicing physicians in business, which is so important to solving this workforce crisis.
Curated from more than 3,000 major newspapers, magazines, and journals, the AMA Morning Rounds newsletter delivers the top stories in healthcare right to your inbox, Monday through Friday. Subscribe today and check out all the AMA's free newsletters at ama-assn.org/myinbox. That's ama-assn.org/myinbox.
What's the political appetite to get any of these things advanced? Have you seen any recent action in Congress that we can maybe be excited about?
Yeah, the best thing about these issues, they're largely nonpartisan issues. Now, immigration obviously has some partisan tinges to it, but even in that context for our issue, it's a workforce issue. But when it comes to payment reform, we've seen a lot of inertia on the Hill. We've seen hearings last year in the Energy and Commerce Committee. We've seen a hearing in the Senate Finance Committee last month. We've seen a white paper released by the Senate Finance Committee. We've also seen a working group formed together, and AMA participated in that just recently, providing ideas, the same ideas I just laid out on MEI and budget neutrality and MIPS reform. We're going to see the Ways and Means Health Subcommittee look at physician payments. The House Budget Committee is also going to look at consolidation and physician payment issues. So a lot of inertia. I will say this, I don't want to overpromise here, and my crystal ball is still a little bit hazy as it relates to what's going to happen at the end of the year. But I will say that a lot of it's going to depend on what happens in the elections here. And I think we all agree that the United States needs to have an election. We need to figure out who's going to be in control of both chambers for 2 years. We also need to figure out who's going to be in control of the White House for the next 4 years. Once that shakes out, we'll have a better sense of what the Congress wants to do, in addition to what the either new or continuing administration will want to do. Then we start looking at offsets. And when the offsets are available and you see who's in control, we'll have a better sense of where things come. But I think it's undeniable that there's some inertia behind these particular issues. And we'll see something in the lame duck session. And that also holds true for the GME legislation as well. It always comes down to cost, but there's a strong support to try and do something on that. We've seen the Health Committee put out a lot of different proposals, and obviously the Resident Physician Shortage Reduction Act is always a central part. So I think we've got some confidence here, and we just got to see how things shake out and continue to press the case.
Well, speaking of seeing how things shake out, obviously I do want to make sure to remind folks that the AMA is a nonpartisan organization. We work with all elected officials on both sides of the aisle, and regardless of who is in the White House and who is controlling the chambers in Congress, sometimes it just provides different policy opportunities for us based on those priorities. And there's no shortage of things certainly that we need to do. And the good news is we've got some of the brightest, hardest working people in the universe focused on this, including the three panelists, Chris, John, and Alexis, each and every day trying to bring forward these solutions.
That was part one of this two-part series. This has been Moving Medicine, a podcast by the American Medical Association. Subscribe today to never miss an episode. Thanks for listening.